coming, everybody. We're going to get started. Thank you guys for coming from Helena. That's great that you drove over this morning. And we also have a couple of our partner agencies represented here this morning. We've got Robin from Partnership Health Center. Very glad that you're here. And also Anna from the Forum. I don't think I missed anybody. I think that's everybody. So thanks for coming. And this, I think, is going to be really great. So we will all talk the same data language after we're done. So.
Sure. So, hi, I'm Heather Zimmerman, and I'm going to start the presentation. I think we can maybe just all introduce ourselves as we go, unless you guys want to do now. Okay.
Yeah, do it now.
So I work with the Coordinated Chronic Disease Program, so I work across the Chronic Disease Bureau on a lot of different projects. And
I'm Jessie Fernandez, and I work primarily with the Asthma Control Program.
And my name's Laura Williamson, and I work with the cancer control programs, and I'll just say that we're all epidemiologists.
Oh, yeah. So.
And then I'm Lisa Schmidt, and I work with the Tobacco Prevention Program and the Nutrition and Physical Activity Program.
So we can just go ahead and get started on the presentation. Oops, wrong one. So first we're just going to start at the beginning and talk about summary measures. So there's a couple different ways that we sort of measure things in public health, and so I'll just go through that. So we've got counts, which are the easiest because it's, everyone understands counts. It's the number of things that happened in a given time period or a given place or whatever. And then we'll go into a little bit more detail about ratios, proportions, and rates, which are really the more useful measures, so also more complicated. So a ratio is a comparison of two numbers. So it's sort of like, well, I have some examples, but you're saying how many of this compared to that, and they're not a part of each other. So that's sort of like the important distinction for ratios. And one example is here we have a map of the school nurse to student ratio by county in Montana. And so that's a thing where you want to know, well, how many school nurses are serving the students, but they're not a part of each other. So it's a ratio. You can also have ratios of like how many females to males. It's the same kind of thing. So that's ratios. Oh, here's an example from public health. So you could say the abortion ratio per live birth. So that's a way to sort of measure how many abortions are happening versus births. And in this example, the numerator then is the number of abortions. The denominator is the number of live births, and you just divide them, and then that gives you the ratio. A lot of times ratios will also be sort of multiplied by a constant, mostly so that the number isn't really small and hard to interpret. So in this example, the constant is 1,000. But the constant is something that we just sort of pick on our own. We usually do either 1,000, 10,000, 100,000 measurements like that. So that's ratio. And then proportion is a little bit different because you're comparing one part of a whole. So you're saying the numerator is part of the denominator, like the percent of adults who are overweight. So overweight adults are part of all adults, and you want to know what is the percent. So that's proportion. You can see it as a percent, but you can also write it in other ways per 1,000. So that's why sometimes it's a little bit confusing between ratios and proportions, because they can be written the same way, where you've got a number per 1,000 or something like that. Here are some examples. So these two pie charts show the cause of injury. So the denominator for this one over here is all deaths that are caused by injury. But some of those are caused by falls, some of the poisoning, motor vehicle crashes, and so on and so forth. So you can sort of see, of all injury deaths, what are the biggest causes. Same with the hospitalizations, the same kind of example. So let me ask you all, for that injury example that we saw, what is the numerator? Not the actual number, but just describe what the number is. Don't be afraid, I'll call on somebody. Yes?
It's a part of the whole.
So,
Which would be like the specific kind of injury out of all
Yeah, yeah. So like the number of injuries caused by falls is the numerator. And so then the denominator would be the total number of injury deaths. Yep. Or injury hospitalizations. That's right. Good job. See, it's not hard. You just have to feel confident to speak up. And then rates are the ones that are sort of used the most often in public health, I think. And it has the added component of time. So the rate measures the number of events over a population at risk within a certain period of time. So that is sort of the most common, I think, measure that we use in public health as it relates to disease and stuff. Well, maybe not the most common. Proportions are up there too. And so for what we call the crude rate, it's again really simple. You just take the number of events, whatever the count is of that you're interested, divided by the population at risk within whatever that time frame is. And then often we multiply it by a constant again. So we have, you know, deaths per 100,000 population or something like that. So that's what we call crude rates. Here's an example from emergency departments. So if we were interested in knowing the rate of asthma emergency department visits, we could find the count of the number of visits that were related to asthma, and then the population at risk for emergency department visits due to asthma are people with asthma, right? And so then we can just pick our constant of 10,000, because that makes sense. And it's the same kind of thing, that we put the count over the population at risk and then multiply by the constant. And that gets us our rate of 259 ED visits per 10,000 people with asthma per year. So the per year is important. A lot of times we leave that out, but it is an important thing to note, because that's one of the things that really differentiates rates from other kinds of measures that we do. Oops. Oops. There we go. And then these are just sort of some tips that relate to how we interpret these measures, and we'll definitely have more examples through the day and more chances to go through this, especially when Laura starts talking about how we apply these measures to public health and how we measure disease and such. But a few things to keep in mind up here is that a lot of times your numerator and your denominator are from different data sources. So the school nurse example is one where we measured the number of school nurses through a survey, and then we got the number of students from, you know, OPI enrollment information. And so there's two different data sources, and that is true a lot, especially when we're doing rates, because we're going to measure the count of whatever the event is, and that'll be measured one way. And then we have the population at risk, and that's usually measured through the census or other things like that. And so the reason that we point this out is because all of those different data systems have their own errors associated with them, their own imprecision. And so it's just important to keep in mind when you're interpreting these, where did the data come from? Is it a source that is pretty reliable or maybe not so much? And so that's something to think about, especially when you're calculating your own rates. Another thing is time. So the length, but when we're talking about rates, the length of time that you follow someone, a lot of times we just assume that everyone in the population was there for a whole year, but we know in real life that that's not really true, that people move around or stuff like that. So it's to keep in mind that a lot of times the population is measured at, you know, one certain point in time, or it's an estimate based on the census that we know only happens every 10 years. And then also the disease count will be sort of have its own thing. So first of all, it's good to know what is the time frame. Is it 1 year, 2 years, 6 months, a month? It can be all sorts of different things depending on what your data source is. And then also just to remember that a lot of times, especially for long time periods, we're going to be measuring at one time in that year and just saying, well, that's representative of the whole year, which is, you know, not bad, but it's just good to keep in mind. And then the last thing is that sometimes you have to ask yourself what really is the population at risk. So it's easy to just say, well, all of the population, but maybe you're talking about something that only affects adults, in which case, obviously, you need to limit your population to adults. Or like with the asthma ED visit, I mean, maybe you could make the case that anyone is at risk for having a respiratory issue, that even if they don't have diagnosed asthma and go to the ED, it's possible. But also, for the most part, people with asthma are people that are going to need to have emergency care for asthma. So that's the other sort of tip. So that's basically it for this first part. Does anyone have any questions about these measures? I know that this is just really scratching the surface, so maybe you haven't thought of anything yet, but yeah.
Well, so then when people talk about obesity rates, that probably are using the wrong term, because generally people say 2/3 of adults are overweight. That isn't really a rate then.
Yes, that's correct. Yep. Yeah, which we actually were going to point that out later even. But yeah, thank you for observing that. That is a proportion. And people do say rate a lot, but because of the way that we measure obesity in adults, we can't really calculate a rate. So yeah, thank you. All right. In that case, I will let Laura take over.
Okay.
So,
applying summary measures to disease. So summary measures, we talk about the extent of disease in populations in terms of incidence, prevalence, and mortality. Are those terms somewhat familiar to folks in the room? Yes. Is incidence and prevalence always a little bit gray? Like, oh, what's the distinction between incidence and prevalence? Maybe. Well, let me go into these terms a little bit more, and I'll give you some examples.
Could you speak up a little more?
Sure. I wonder if my mic is catching too. But anyways, so I think of the summary, or the how we describe disease, the extent of disease, kind of using a bathtub analogy. So the incidence is your number of new diseases that are occurring in your population, and they're filling up your bathtub. And then your bathtub is contains all your population at risk, and the level of your water that has filled up the bathtub is your prevalence, which is your existing disease cases that you're looking at. So these are brand new cases that were diagnosed 1 month ago, 5 years ago, but they're still alive. And then the hole or your drain of your bathtub could be, it represents either mortality or cure. So in order to leave the bathtub from your disease pool, you either need to be cured or you die of that disease. And so that's one way to think of incidence, prevalence, and mortality. Let me give you some examples. So incidence is the measure of new cases of a disease among a population at risk over a period of time. So an example would be that we use incidence measures for would be cancer. We measure that in incidence rates, where we always measure the number of new cases diagnosed usually over a year or several years, and then we usually put it in terms of a constant, as Heather was talking about, per 100,000 people. Some other examples would be the notifiable diseases that you report to the state. So that would be influenza, pertussis, other notifiable diseases. Hospitalizations would also be usually or almost always in the form of incidence. And so these incidence is always reported as either a number of cases, or it's reported as a rate. Prevalence, on the other hand, is the measure of existing cases of a disease at a particular point in time or over a period of time, a period of several years. It's often reported as a percentage, and we usually use what we call, this is really specific, but a point prevalence, because we measure it at one moment in time, but we will say that the measure kind of represents a whole year. So for example, the obesity prevalence, which is a proportion, we would say that 60% of adults are overweight or obese, And how we got that 60% is we measured them. We called a bunch of adults one day of the year, and then we say that represents the whole year. And then the example I gave, here's another one, is of adult smokers. The prevalence of adult smoking in Montana was 19%. And smoking is another one that we often, in conversations, will say the smoking rate in Montana is 19%, but that's technically incorrect. It's the percentage or the prevalence of people smoking. And then mortality measures death in due to a particular cause in a population over a period of time. And again, similar to incidence, we measure this in terms of numbers or rates.
So,
Question.
Getting back to the obesity rate versus prevalence. So we measure most third graders in Missoula County for BMIs
Uh-huh.
over a period of a school year.
Yes.
Does that give us a rate?
No, it gives you a percentage.
A percentage, okay, thanks.
Yes. And so you'll be measuring the prevalence of obesity. So you're not necessarily measuring that kids are newly obese over that school year, right? They probably entered the school year about the same weight as when they hopefully leave.
So if you measured at the beginning of the school year and then at the end, that would give you a rate, right? The new cases. I mean,
Yes, if you measured how many new kids, like so at the beginning of the school year you had 10% in obese category, and then at the end of the school year you had 13%, the difference, that 3 percentage point difference, would give you a rate.
Yeah, of the incidence of obesity among third graders. Yeah.
So
Other
when somebody
questions?
Self-reports their obesity, that's a rate? Because that's a measure? I mean,
No, that's
self-reported.
so self-reported there. That's how you're actually counting your number of cases, but they may not be newly obese, and so that's the distinction. Is obesity measures are all prevalence. I don't think we have any measure of incidence of obesity. And so the distinction is incidence is new cases, newly diagnosed, newly found to be obese, whereas prevalence is I've been obese for 1 day, 10 years.
Good questions.
Yeah, good
by the way.
questions. So anything that the State Health Department produces from the Behavioral Risk Factor Surveillance System, that telephone survey, the BRFSS or BRFS survey, those are always prevalence estimates. That survey doesn't measure anything new. Other questions?
So be considered as self-reported
Yep.
piece of data.
Mm-hmm. Okay, so if it helps you to think of the bathtub again, so your incidence is your new cases filling up the bathtub, and with the faucet you can turn it to pour in slower or faster. And so think of that as the rate, right? So the rate of your water filling up your bathtub. And then the water that's in your bathtub is it's filling up proportions or percentages of your bathtub. You're 50% full, you're 75% full. So that's prevalence. And then the rate at which your water is draining out because either people are dying or they're being cured of your disease, that's mortality or cure, but those are also communicated in rates because you're kind of measuring how fast it's flowing out of the tub. All right. Is it you? I think it's you. Oh no, it's still me. Okay. And then the other thing that we do when we talk about rates, especially incidence rates or mortality rates, is we often will say this is an age-adjusted rate. And what that means is that the disease let me back up. Disease and death are often associated with age. So we expect older people to die, and we expect older people, for example, to develop cancer. And we might expect younger folks to have asthma. And so when we want to compare two different populations, say the state of Montana to the state of Florida, or we want to compare Missoula County to Billings, we need to take into account that each of those populations has different age structures. So for example, Missoula is probably a younger county than Billings. And so when we talk about mortality rates in Missoula County versus Billings, we want to make sure that we're not overestimating mortality because one population is much more older and therefore more likely to die than the other population. So basically, it's a way, when we age adjust rates, it's a way to make it a more fair comparison, and we're essentially washing out the effect of age. So as I said, we do this when we compare rates of geographic areas, and then also when we're comparing time periods, like the 1990s compared to the 2000s. We might have different age structures in, say, Montana. So to illustrate this a little bit more, I have a graph that's showing the median age of Montana. This young age is at the bottom, and this is old age, and this is kind of the percent of population that's in each age group. So both populations are centered around middle age. It kind of looks to me like Florida leans a little bit this way towards the top, towards the older population. But the average age of Montana is 39.6 years compared to Florida, which is 41.5. So Florida's a little bit older than Montana. Okay, so then when we look at the number of, this is cancer mortality, the number of cancer deaths that occurred in Montana was about 1,900 cases. And in Florida, there was about 41,000 cases, cancer deaths. And the difference in the number, of course, is why? Population, right? So the absolute count doesn't really tell us much about what's going on with cancer deaths in those two states. So then we'll put it into a rate per 100,000 people. So now we've kind of evened out the playing field as far as the differences in the populations of those two states. And the mortality rate in Montana is 194.1 per 100,000 people. Meanwhile, Florida is 220 per 100,000 people. So what do the two rates tell us about what's going on in the two states?
More people die of cancer in Florida.
Yes, right? So, so the crude rate is telling us right now that more people are dying of cancer in Florida compared to Montana. But then if we age adjust those rates, meaning we've washed out the effect of the different age structures of those populations, we're now getting, it's at the very bottom, an age-adjusted mortality rate of 159.8 per 100,000 people in Montana, compared to Florida, which is 163.9 per 100,000. They're much closer now. And if we did some statistical magic on them, we'd probably find that they're statistically the same death rate. Okay.
This is me.
Yes, this is you.
Did you guys have questions on the age-adjusted rate before I dive into something else? None? Okay. So I'm going to talk about measures of uncertainty, because with all these measures that Laura and Heather just told you guys about, all of them come usually with a margin of error, right? Or this measure of uncertainty that usually represents itself behind the number in a form in parentheses, and it'll say, you'll have a 16%, and then behind it in the parentheses you have 14 to 18%. Have you guys seen those, how those are written out there? So that what comes in the parentheses is what's called our measure of uncertainty. And that's because the way that we capture all these numbers, usually in public health, is that we do surveys, right? We love surveys in public health. And because none of us have the resources or the time to go around and survey the entire population that we're interested in, we always end up with a sample. So we try and do our best to make sure that that sample is somewhat representative of our target population as a whole, right? But regardless of how good we are at doing that, there's always going to be some sort of unavoidable error, and it's just called sampling error. You can't prevent it. It just exists no matter how good your sample is. And so a few things that can help minimize that error are if you have an unbiased probability sampling, and that means that you go through some measures to make sure that your population is very representative of your entire population as a whole, which is why people often get frustrated in other parts of the state when some statistic is given for Missoula and then it's extrapolated to the whole state, and they say, well, we're not like Missoula. Like, you can't compare us to Missoula. We're very different. And that's because they also think that their sample population is much different than the makeup of this one. The other thing that helps with these are really large samples. So the bigger your sample is, the more people you have, then the less error that you're going to have within your sample. Okay. And then this is just the terminology. So this is sort of what they're called. You have a margin of error, a standard error, and then confidence intervals. And those three things, we're not really going to go through the difference, but just all of those are measures of uncertainty that let you know, okay, this is just an estimate, and really it has a little give or take on one side or the other. And we'll go into confidence intervals in more detail. But first, I just gave a few examples here, I guess. This is like one that you guys have seen, I'm sure. I just said that 58% of Montana adults have had at least one drink of alcohol in the past 30 days. And then the confidence interval associated with that is 57 to 60. And we'll talk about how to interpret that in a minute, but just know that that's sort of the range. So it's saying that this is the estimate that we came up with, that 58.8% based on our sample population. But really, it's sort of this whole range. It could be anywhere right here in this range. And then the other place that we often see these now is because it's an election. Elections are coming up, and polling practices use margins of error all the time. So this is just to say, this came out, the latest so-and-so survey found that 64% of likely Republican voters think Donald Trump will likely be the next GOP nominee. So then, give or take that as you will. And then if you read further down, they always in small print somewhere usually have something that says, here was our survey. The margin of sampling error for this is plus or minus 3 percentage points for a 95% confidence level. So meaning that 64% could really be 61% up to 67%, somewhere in there, based on their sampling method.
So what does the 95% level of confidence mean?
We will come.
They're pretty sure? Okay.
Yes, well, we will talk about that here shortly. Yes. Okay, but first we're going to do a little sampling activity just to sort of make it a little more clear what sampling is. So for the sake of, it's right after Halloween, and it's early, and y'all probably need a little activity because we're talking about data for 2 hours. So I'm going to do 6 groups. Since there are 6 tables in here, it'll make this easier. And for you guys in the back, I'm just going to ask that you come and maybe 2 of you tag onto the front tables because there's more room, and then 1, just sort of distribute yourselves amongst the 6 tables. So for us, our population as a whole that we have is going to be all the M&Ms in 6 bags of M&Ms, right? That's our entire population. Each of your tables represents a year. So we're going to survey this entire population 6 different years. So I'm going to assign you all years, and then you're going to take and count out how many people, M&M people, are in your population. And then we're going to do blue M&Ms. So what I'm really curious about then is the blue M&Ms, and they're going to represent the tobacco users, okay? They're asphyxiating, they're turning blue, whatever analogy we want to use. We're going to do the blue M&Ms. So I want to know from each different group, 1, how many blue M&Ms, what percentage of your population is smoking, and then what's your total number. So total M&Ms and then your blue M&Ms. And then we're going to record some things up here on the board, and we'll use them later. So I'm going to give you each a bag.
I'm going to help pass out.
Yes, would you please? So if you look at this board over here, so we said now that all of you guys, we said are 6 different samples. So we're going to pretend like we did this all in the same year, but as a survey, I chose 6 different population groups to look at, right, all at the same time. So numbers 1 through 6 up there, that's how you all fared. So pretty consistent along the bottom. 20%, 22.8, 19.6, 18.1, 27.7, so we'll talk about that one. It's kind of good, it's like that. And then another one that's 19%. So had you done a survey and done a random sample of 100 and a little over 100 people, every time you would have gotten a percentage that's down there in the 1 through 6, okay? What we never know in public health, which is frustrating, so this total over here, right, that we have a total of 611 M&Ms. This we know. What we don't ever know is exactly what the percentages or the prevalence is in whatever disease we're looking at or condition we're looking at, right? Because we're never actually able to survey this entire group right here. So this number, just know this is an unknown. This is our best guess. This is what we have to do as epidemiologists and public health professionals in order to estimate what our best guess is of what these different health conditions are. And so that's why we have this margin of error, this confidence interval, which I'm going to talk about right here. So what we would have done with, let's say, sample number 1 here, it's got a 20.2%. Using statistics and knowing what the population makeup is and using a complicated formula that I don't remember because computer programs do it now, it comes up with a 95% confidence interval to go behind this number right here. So maybe this goes from 18.2% up to 22.2%, okay? So for each of these, they're going to come up with the same, like a confidence interval based on that population. And how we interpret that is on my next slide. And this is saying the same thing sort of that we just did. This is using an actual survey, the BRFSS survey, and their sample size of Montanans is 9,300 people. And they sampled once. They had a group 1, and it said, okay, in this group of 9,300 people, 24.6% of them are obese. And there's our confidence interval. So now the way you interpret that is you say, okay, if we looked at all of the different samples that we could in Montana of 9,300 people, and we just kept pulling out sample after sample after sample, 95% of those intervals would contain the actual estimate of obese people in Montana.
The truth.
The truth, that we don't know what it is, but knowing that statistics work the way they do, they are saying with 95% of the time, we're going to get it. 5% of the time, we're not, which is actually the case. If you look at group number 5 up there, and that was the sample that we happened to do for the year, that 27.7%, most like, it's kind of an outlier. But we have no idea that that's the case. It happens. So 5% of the time, those health estimates that you get aren't necessarily going to be the best estimate of what's going on within that population, which is a bummer, but yeah.
Is 95% confidence interval kind of the standard for public health?
It is. It tends to be the standard for public health, yeah. For really almost any sort of statistical thing, yeah. Uh-huh.
So the truth is somewhere between 23.4 and 25.8.
95% of the time, yes, correct. Good interpretation. That 95% of the time, the truth is somewhere in that estimate. And this is another visual, just sort of to make that clear. So if we're saying, here's our truth. This is what, if we were able to ask every single Montanan, this is what it would be. This is the truth. We don't know. This is the number we don't know. And so then we're going to get a sample. If we were to do 20 different samples, right? The first one, here's our estimate. And there's the blue line represents the confidence interval. So here's the point estimate, and then I just did a blue line that runs from 22.6 to 24.9. So that's what these blue lines mean. And we did this, 20 times, 20 different samples. Here's where they all end up. Here's all the different confidence intervals down the way. So 95% of the time, these estimates, they cross over where the actual estimate is. So it's saying, yep, that true estimate is somewhere within this confidence interval. One time, right here, that's the 5%, it just happened to fall outside of the range. And that's just the nature of statistics. You guys have questions on those at all? Does that sort of make things a little bit more clear as to why? And that's why everyone gives estimates with a confidence interval, because they're just recognizing that we know there's a little variability that exists in here. Okay. So the other cool thing about confidence intervals is that they can tell us if two estimates are significantly different or not. Because you know how a lot of times, you know, in a newspaper article, you'll see, ooh, smoking prevalence in Montana has increased to 20% from 19% last year, right? Yes, like 20% is higher than 19%, but there's no significant difference in those two estimates. And the way we tell that is by looking at confidence intervals. So if those two intervals, you've got two estimates, they both come with their intervals. If those two intervals overlap, then there's no real difference between those two estimates, okay? Because it's just saying, oh, there's some overlap here. So really, the true estimate could fall where that overlap is, meaning that those two estimates aren't any different from each other, statistically speaking. Whereas if you have two intervals that are far apart from each other, then they are different. I'll show you an example that's more of a visual. It's a little easier. So if we want to know, are these things significantly different? So we've got 10.3% of youth, sorry, I use smoking because I work in tobacco, smoke in Montana versus 13.9% of youth smoke nationwide. So you look at those two confidence intervals right there. So these are our estimates, right? 8%, 10%, 12%, 14%. There's Montana. That's our 10.3% spans from 8.2 up to 12.4. That's one interval. Here is the interval for US in the US, for youth in the US. It spans from 11.8 to 16.0. So are those two things significantly different from each other? No, right, they're not. Because really, maybe it's right here. Oops, I shouldn't touch that. Maybe it's right there in the middle, meaning that, oh, actually those two could be the same. There's no significant difference in those two numbers. You cannot say, uh-oh, or yeah, Montana, you're doing great. Our youth are smoking significantly less than youth in the US. We can't actually say that. No. There it is. I gotta put that in. So then how about this? Same two estimates, right? 10.3% of youth smoke in Montana versus 13.9% of youth nationwide. So these samples must have been bigger, right? They either had a bigger sample size or they had a better sampling strategy because their confidence intervals are smaller, meaning that they have more certainty about their estimate. So if you do the same thing, here is Montana. There's their little confidence interval. And there's the US. Now there's a gap between those two, right? So now you can say, awesome, Montana and their tobacco prevention workers, I see one right there, yep, are doing great because the youth in Montana are smoking significantly less than youth across the US. Yes, great.
So which is the real one?
I would have to go back and look because I don't actually remember. And the numbers are new now, so I don't know.
Probably the top one is, I would imagine.
Yeah.
So that's a pretty high, if it's the top one, that's way more than 95%, or way less.
Well, so the way that we decide how wide the confidence interval is a very complicated math formula. We spared you from it because, like Lisa said, we don't ever use that. That's why we have statistical software. But it's determined by how big your sample is, what kind of sampling strategy you have, how big the point estimate is, how big the total population is. There's a lot of things that go into that. So you can't look at the width of it and say, well, that can't be 95% confidence because it's too wide or too narrow, because that's not really how the thing that determines it. Does that make sense?
So that, yeah, the 95% doesn't correspond with the percentages of up here.
Oh, I was just saying like 8.2 to 12.4, that isn't a 5%.
Yeah.
Right.
Yes.
Yeah, because yeah. That's the yes. No. The 95% confidence interval is just saying that 95% of the time it will contain that true estimate. Yep.
Yeah, so a 95% confidence interval could be like 10 percentage points wide if you've got a really small sample, or it could be like half a percentage point wide if you've got a really big sample.
Yep.
So the size of your sample is usually the thing that really makes the big difference in how wide or narrow it is. There are other things too, but.
Mm-hmm. Yes. Other questions? Good question. Yeah.
My question was just how do you do sampling for like you smoking in Montana?
So this youth smoking sampling comes from a survey called the Youth Risk Behavior Survey, and it's administered to all the high schools, have a chance to complete it, and they usually have a 70 to 80% completion rate. So 70 to 80% of high schools in Montana, their students complete this survey, and then they take all of those responses, and like Laura talked a little bit about adjusting for age, they do what's called weighting. They send that sample to the CDC, and the people there weight it so that, you know, if the 70% that answered were mainly from really big high schools, then, and only a couple from really small ones, then they can do a weighting procedure so that it evens it out, so that it's proportionate to the number of big high schools and the number of little high schools in Montana.
So all samples should be a probability sample where maybe not everyone has the same chance of getting selected, but you know what their chance of getting selected is, and it's random. It's not based on, you know, just saying, yeah, I want to do that or not. So yeah, so that's how where BS, well, it partially works, where CDC has a list of all the high schools, and they have some sort of random way to pick, these are the 20 that we're going to talk to each year, or every other year.
So if they don't, if the class or a school doesn't fill it out, is there any way to know how dependable, because you're kind of depending on the random sample to rely on the data, but if, how much flexibility is there in that going wrong or being off?
So that's, I mean, people have done a lot of research into answering that question, and that sort of goes into the weighting. So, so we don't know very much about the people that didn't do the survey, because they didn't do the survey. But we do probably know like how many students are there, and we probably know like the proportion of male and female, and like the socioeconomic status, because the school has that information from their enrollment records. And so they can use that to sort of compare the population of people that took the survey and the population that didn't, and sort of say, is it look like they're the same or not? And then we can use weighting to say, well, it looks like people from bigger high schools mostly completed it, so we need to count the answers of the small high schools more, so that they can represent all of the small high schools, even though, you know, only 3 of them answered, or, you know. Does that make sense to people?
Yeah. It gives the answers a voice that's, you know, proportional to how many of that group exists.
So how do they decide what that voice is when you do a sample, like the YRBS and then the one about Donald Trump? I mean, 1,000 people out of America doesn't seem very significant, but people run with that. And same with the YRBS. How do they decide about a high school of 2,000 people? Who decides what the sample number should be?
So they set target goals, they do, and a lot of times they're not met, so it's a good question, but they know overall what the population of the high school youth is in Montana, so they do know that, and then all they can do, the best they can do, is take that group that answered those questions and see how closely the age and, you know, geographic breakdown of that group matches the whole state.
Yeah, and so they set their target sample size based on sort of the statistics of how many people do we need to get to be able to have a reasonably small confidence interval. And so there's a lot of math, and it's really complicated. But yeah, they do that. And then for like those political polls where you mentioned that's a totally different system. Political polls have like way different standards than
They do. It's strange.
Yeah.
But it is, and that, you know, I think that one said too, it said 64% of likely Republican voters. And so, you know, the polling, they have access to data that probably some of ours, the majority of it, you know, will fill something out or will vote a certain way, and then all of a sudden you are categorized as a Democratic voter or an independent voter or a Republican voter. And then there's census data that's out there that sort of does the same thing. So they take whatever information they have available on people that are likely to vote Republican and then sort of come up with their estimates from that. Not always, yes, as rigorous as the scientific side of statistics.
Isn't, like, there's always a human component no matter how much the computers can do, because you have to tell it what, like, if you don't, say, account for ethnic populations and you don't tell it to, then you don't represent that in your sample or weight it or whatever.
Yeah.
So
Yes.
you have to know what affects smoking rates or what affects obesity rates.
Yep. Exactly.
Or what affects who's going to vote.
Who's gonna? Yeah. Yes. Yep. Which is why when you read different statistics, always do so with a grain of salt, or read the fine print so that you can see, did they adjust for all of those different groups, or is it just sort of a blanketed statement of?
Yeah, that brings up another like little pet peeve of ours is when people don't cite the data source, because you really can't interpret statistics unless you know where it's coming from.
I would also argue
these articles are notorious about that.
I would also argue you can't really do anything with statistics unless you know the confidence interval, or sort of you can't compare them, I should say. You can't ever really compare to unless you know what their margins of error are. Great. Are there other questions? These are data people, in case you wondered. They do get excited about data, so we threw them in there.
I'm going to pull that quiz up and then we'll do the break.
Oh, perfect. Okay.
Yeah, so we have another interactive activity for you. We have some quiz questions. And so what we were thinking is that you guys could sort of test your own knowledge. Can you read that? We might need to make it bigger. But the thought is that you could sort of work on this on your own or in groups at the tables and take a little break if you need to, and then in 10 minutes we'll go over the answers. Does that sound like a good plan? I don't know if we
can you read those even? No. You can? No.
Can't seem to get it to just...
We should have probably printed this out, but we didn't, so.
There we go.
Well, maybe we're only, that's still too much. We might have to do it as a group. So maybe we'll just.
Break for like.
Yeah. Yeah.
We can do this.
Well, I guess we'll only be able to do one question at a time, like, because of the limitations of display. So I guess what we'll have to do then is just take a quick break and then we'll go through them all together.
At 10:05.
At 10:05, yeah, at like 10:05.
Okay, so for those that are back in the room, we're going to refocus. We're going to go through a quiz as a group, and then we're going to move on to like the second part of our presentation. But up here on the screen is a figure, and the title reads, Age-Adjusted Death Rates for Heart Disease and Cancer by Sex, United States, 1980 through 2011. And so the question is, what kind of data is shown here? Is it A, prevalence, B, incidence, or C, mortality? Let's take a show of hands. Raise your hand if you think it is incidence data. How about hands for prevalence? How about hands for mortality? All right, you're correct. I don't know, it might be the death rates in the title that gave it away, but
I think it was the brain break.
And the brain break, for sure. Okay, so then this figure represents A, number of deaths, B, the rate of death, or C, percentage of death. So how about hands for A, number of deaths?
Can you read the
It's hard to read the.
I know.
So on the y-axis there, it says deaths per 100,000 population.
And then the x-axis is year. Okay, so hands for number of deaths. Hands for rate of death. All right. Oh, and then percentage of death? Okay, you all were right. It's B. It was the rate of death.
The dead giveaway is the per.
Yeah.
Although it could be a proportion that's listed like that, but in the title. Oh yeah, the title said rate.
Yeah, it did say rate. Okay, so this title says pertussis case counts by month of report, Montana, comma, selected years. And so the y-axis is not labeled, but it goes from 0 to 200. And then the x-axis goes January through December.
And each of those lines is a year.
And each of those lines is a year. Okay, so what kind of data is shown here? Is it prevalence, incidence, or mortality?
Incidence.
Yep. And then this figure represents, what do you think, number of cases, rate of cases, or percentage of cases? Correct.
Once again, the title was a dead giveaway.
Yep. And it usually is, so read your titles.
Yeah.
Oh, and then we have one last question. Okay, so the prevalence of current adult smokers in Montana decreased from 18.5, parentheses 17.1 to 20.0 in 2008 to 16.8%, parentheses 15.5 to 18.2 in 2009. Was this a significant decrease? Yes, no, or not enough information?
No.
Yep,
Good job.
correct.
You guys all passed with flying colors.
Woohoo! Who needs the mic next?
I think Jessie does. She's got one over there.
I think, did you want to talk about the county health rankings first?
Oh, that is first, isn't it? Okay.
So the next part of the presentation is going to focus on where do we find all this information. If you wanted to know about your community or some other location, where could you go to find those data?
Sorry, could you quickly just grab one of those for the recording?
All right, so we were going to have another presenter, Carrie Pride, and she couldn't join us because of weather. Her roads were a lot worse than ours. So I'm going to go through her slides the best I can. So this is a quote that she put in from Lord Kelvin. One's knowledge of science begins when he can measure what he is speaking about and express it in numbers. So, you know, we're numbers people. We like this. So first of all, put out pretty recently, probably your best source of data at the county level is going to be these county health profiles. I am really biased because I helped a lot with putting together the data, but I do think it's a good data source for you all. So we're just going to go through that. Oh, I keep clicking the wrong way. Okay, so we used a lot of different data sources. We tried to pull as much stuff together for you as possible so you could just go to one place and get a lot of information. So we used U.S. Census vital statistics, which is birth and death records, hospital and emergency discharge data, so the billing information whenever someone goes to either the emergency department or is admitted to the hospital, which is a voluntary system, but we still have a pretty complete record across the state. The Montana Central Tumor Registry, which is very complete, and Laura's in charge of that, so we know it's good. And we used some WIC information, so we know that WIC collects quite a bit of information about the population they serve, so that's a use, I mean, it's not the whole population, but it's a useful data set for that population that get WIC benefits. The Montana Infectious Disease Information System, which you know, you all are responsible for collecting that information within your county and then reporting it to the state so we can sort of look across the whole state. It's another good one. And then the Vaccines for Children program, which is also a pretty good data source. So we compiled a lot of stuff for you, sort of running the gamut of things that you would be trying to measure in your counties. And these are sort of the broad categories covered by those. Demographics, which we mostly got from census. Communicable disease, of course, which is the reportable stuff, and immunizations. Chronic disease, which is mostly measured by the behavioral risk factor surveillance system and hospital discharge, and vital statistics. Mortality, of course, is vital statistics. The maternal and child health, which is mostly birth record kind of data, and behavioral risk factors, which we already talked about too. So the other thing that we did with this is Montana has a lot of trouble with county level data because we have so many counties that are really small. And from a statistics standpoint, it's nearly impossible to get good statistics for them just because the population is small, which means your sample size has to be super duper small, which means you've got huge confidence intervals and you can't really interpret them very well, okay? So what we tried to do to kind of overcome this is group counties according to size, and then if you're comparing one frontier county to another frontier county, even if you don't have a rate, even if you only have a count, at least it's kind of comparable a little bit, you know? And so you know that you've got, you know, sort of a ballpark of like counties. So we hope this is helpful. Of course, we never name out, you know, this is, you know, Mineral and this is Ravalli. We didn't do that. But we just said among frontier counties, this is what it is on average, and this is your rate for whatever county you're looking at. And so that's just how we grouped them. So frontier counties was less than 5,000 people for total population, and then so on from small, medium, large. And then, of course, we looked at the whole state, too. And so Carrie Pride is the person who's mostly in charge of this. So if you ever have any questions about this data source or, you know, how to interpret stuff or what can I do with this, she is willing and able to help. So don't hesitate to call or send her an email or anything. And then we can actually look at the website too. So right now it's a little bit hard. Let's say, ask me later. How about that?
I think you have to say, I might have to say okay.
Man. Well, no, I'm over here. I'll just do this.
Okay.
There we go. And we'll make this big. So it's a little bit hard to find unless you use the URL that's typed in there. So if you, when you're back at your office and you're wanting to look this stuff up, you can go to the to actually type in the URL, because if you try to navigate through the menus, it's going to be a nightmare. We know it's terrible, and I'm sorry.
And I'm just going to say that when our new website is launched, we will have a page called Data and Reports, and this one is on there.
Oh, good, good. So anyway, you can just sort of go through. We have the methodology, which I would love for you all to read, but I understand that you probably won't. It's all right. And then you can pick your county. And we'll just go to Missoula because that's where we are. And you can actually see the report. And they put together a very nice report. It's all formatted and nice looking. Let's see if I can make it a little bit smaller just so we can go through. Oh, that's the wrong one. Yeah. And then it's cool because the table of contents is a link, so you don't have to scroll through the whole report. You can just come down and look and see the indicators that they have. And so for most indicators, we have the county and the state overall. Sometimes we also have in a comparison for among similarly sized counties. Of course, Missoula is a large county, so that's it. And then occasionally, there's, you know, like not available because, you know, when the case count is really small, we don't really feel like we can share it because it's just not, well, first of all, it's hard to make interpretations. And second of all, you might be able to sort of extrapolate of, is this really staying private or not? Which I know it seems kind of weird when you're just looking at a table, but that's what we do. Missoula, Gallatin, and Flathead didn't generally have those problems, but really small counties do. So I guess that's it for these reports. Let's go back to the...
How often are those going to be updated?
We're shooting for every 3 years. So we couldn't really do it every year because for most of these we had to put together several years worth of data to have county level estimates. So we didn't want to be sort of reusing, you know, like 2 out of 3 years each time we put out the report. But we also recognize that you all are having to do county health assessments on a pretty regular basis. So I think we're shooting for 3 years. So it just went out this last summer, or early fall, I guess, not that long ago. And then in 2018, I guess we'll try to put out a new one. So. And then I'll let Jessie talk about the state trauma registry.
So there are several kind of registry type data sets that we maintain at the State Health Department. Laura's going to talk about one for cancer, and the other one is for trauma. And it's a registry of all of the severe injuries, so those that activate the trauma system. That wouldn't count something that you might consider an injury like a poisoning. It's those that are severe trauma injuries. It is a voluntary system. It is pretty complete, but the sites that have trauma registrars report into the system, and then a few that aren't trauma designated also report. And like I'll talk about in a minute with the hospital and ED data, it includes people who are transferred to multiple hospitals. So we can't de-identify to an exact person who maybe was seen at 2 different hospitals. We just know that there were 2 encounters at trauma hospitals. There's quite a bit of information in the trauma registry about demographics and the manner of the injury, as well as then some other information that you typically can't find in other data sets. Maybe MDT, the Department of Transportation, might have some information, but things like toxicology screening or protective devices that have been used, seat belts, life jackets, protective clothing for motorcyclists. So if you are interested in some trauma registry data, you might be able to contact your local trauma registrar here, or you can talk to Luke at the State Health Department and see if there's some questions that can be answered for you. We also have data on injury and injury deaths through a system that CDC maintains that is called Whiskers. I'm going to not remember what the acronym stands for, but the website's here, and I passed out the sheet that has a lot of the websites that we're going to talk about up here, so you can access those at your desk, and in a little bit we'll try to go through a few examples as well if anybody wants to look specific things up. Like Heather was talking about, vital statistics refers to the death certificate data, birth records, marriage and divorce records, and I believe the abortion records. And they have access to the death certificate related data. It's a lot of the information that comes off of the, basically all the information that comes off of the death certificate. So underlying cause of death and up to 20 contributing causes of death, and then your demographic information, as well as some things like tobacco use. Sometimes that's complete, sometimes it's not. And then manner of death, was it intentional, unintentional, was it not known, homicide? Were you going to say something?
Yeah, I think maybe I shouldn't say anything because I don't really know, but I think that they were adding a field where people could check whether or not the death occurred on a reservation and which one. I'm not sure if that actually got added or not, but it's if it has been, and I think it was a couple years ago, after several years where people start to get used to filling it out, then you have complete enough data that you can actually use it. So that's another thing.
Mm-hmm.
Yeah.
So how many years does that have to be?
It just depends. It depends upon how fast people get the coroners and medical examiners get used to filling it out. I'm usually 2 or 3.
So data off of the birth certificate includes information about the baby, the parents, as well as some of the information about prenatal care that was received, method of delivery, the birth outcomes, and then breastfeeding status at the time of discharge from the hospital. And all of the vital stats data, I'll give you the contact at the State Health Department, but you can also find a lot of it online through CDC Wonder. The website's up here, and then there are a few other. Todd in the Office of Epidemiology and Scientific Support is your contact at DPHHS. So we also have discharge information on emergency department visits and hospitalization, so inpatient visits. They come from pretty much most of the hospitals around the state, though it is considered a voluntary system. I think they get about over 90% of the discharges in those data files. like the trauma registry, it can't be deduplicated. We don't have individual names or some way to identify cases so that we could say this person was seen at this hospital and then they were transferred to this hospital, or you know, so it's just down to being able to report number of encounters in a hospital or emergency department.
Jessie?
Yes.
Can I ask a question? Could you speak to the legislative attempt to address the voluntary information that's on a birth record? Were you guys involved in that at all?
I wasn't.
To decrease the amount of information
Oh.
that's gathered?
I don't know much about that, do you?
I
No.
was not.
Mm-mm.
Yeah.
Sorry.
It's probably our state epidemiologist, Carol Ballou, was involved, but
Yeah.
we weren't, so I don't know.
It had to do, I mean, that people who, like us, who rely on data, and some of it, a lot of it's voluntary data, some of it isn't, to make decisions and to understand how to help, you know, with health issues can really get hobbled if people start talking about right to information. So
Sure.
it's a really interesting topic that comes up almost in some form every legislative session.
Yeah. Well, and I know that, I mean, I'm not sure about the birth certificate, but I mean, I know that we have tried on multiple occasions to get the hospital discharge data not be voluntary, to have it a regular mandatory reporting, and have failed every time. But we, you know, we keep trying. Yeah.
There are several pieces of really great information that you can get out of the ED and hospitalization discharge data files. Age and sex, how long they were seen at the hospital, or typically for emergency department it's not going to be days, but their primary diagnosis, so the primary reason they were there, that's not chief complaint, it would be what they're discharged with, and then up to 8 secondary diagnoses that they received during that visit. The procedure codes, and then there are up to 3 E codes or etiology codes. Those are usually what are used to help classify injuries. That's telling you about mechanism of injury or place of injury. And then the total charges, that's what the hospital charged, not necessarily what they were paid. And then county of residence of the person who was admitted. So you can contact Cody in the Office of Epidemiology and Scientific Support if you want to know more about ED data and hospitalizations, and their website up there.
And so until really recently, we weren't allowed, so we got this data through the Montana Hospital Association, and they put, you know, in the user agreement that we wouldn't ever report data on the county level, because a lot of counties only have one hospital. And so they didn't want to identify, you know, this hospital has this rate, which is understandable, but that has actually just really recently changed. And so in the county health profiles, we do have county level data for hospitalizations. Of course, that's not always going to be reported because of small numbers, but I think that that's important to note, because if you've looked into it in the past and been told, no, we can never do county estimates, it's different now.
We still can't compare hospitals. So
oh, no, yeah, we can't identify what the hospital is.
Yeah.
Can you do re-hospitalizations?
I don't believe currently that there's a way. So these data come off of the billing form that is submitted after someone's been discharged. And I know that that's been in discussion, but I don't think currently that those data are being collected to know if it was somebody who had been seen in the last 30 days or something.
Yeah, because we don't have any identifiers of the person. So if they were admitted and then 10 days later after they got home were admitted again, it would look like 2 completely separate events. And we wouldn't be able to link.
Have that data.
Yes.
They could.
Yeah, it's just not.
It's not collected.
It's not on the billing form, so.
Oh, I see.
Yeah, so Laura was going to, any questions about vital records, hospital or ED? Yeah.
At some point, could you show people CDC Wonder?
Yeah, as soon as we finish up with these slides, we're going to go through a couple of examples. We'll just take some requests and we'll go through and try to find it.
Okay, so I'm going to talk about the Central Tumor Registry. Cancer, surprisingly, is a reportable disease by state law, similar to the infectious diseases. It's the only chronic disease that we have incidence data on, so we know a lot about new diagnoses. What does this slide say? Yeah, so registry information, it contains information on new cancer cases. We also collect information on the cancer treatment that the patient receives, and then we follow patients until they die. And so every hospital, physician's office, pathology lab that either diagnoses or treats cancer in the state of Montana must report to the state health department. And then we also have data sharing agreements with over 40 of the 50 states. So when our patients, our Montana residents, go to, say, Seattle for cancer treatment or diagnosis, the state of Washington will later send the Montana Health Department a report about that person's cancer. So we have very complete information. We have been in existence since 1979, and we estimate that we have about 95% of the cases that occur in the state we have record of in our database. So the data that's available from the Central Registry are demographic data about the cancer patient, treatment information such as did the patient have surgery, radiation, chemo, a combo of them, which facilities they went to, so we could tell you about like where Missoula patients are having to travel for cancer treatment or if they're staying in town. And it is easily comparable with other states. So all 50 states have a central cancer registry. We're across the country, a very organized group. We all collect our data the same way. We all code it the exact same way. So we're very highly standardized and easily comparable. Unlike the hospitalization data, we have data about individual patients. So we say that it's not duplicated. So when we get a report from say Kalispell and Missoula on the same patient, we combine that patient's information from all the facilities, so we have basically a history or a story of that person's cancer experience. And so we can follow individuals and see what has happened to them from diagnosis to cure. And then the level of information that we can release, of course, is dictated by privacy rules, and we're always concerned about the patient's privacy, the physician or the treating hospital's privacy. But I personally try to give out as much information as I can.
Do you have a question?
Did someone else have a question?
I'm curious if, I've just seen in other states how they do hotspot mapping with cancer rates and to see if there's different parts of that state that has higher cancer rates, and then trying to figure out how to solve the problem, especially if it's environmental or socioeconomic.
Yeah.
You know.
So
are we doing that in Montana?
We're getting to a point where we could start to do hotspot mapping. I recently geocoded several years of data, so now I can put points on a map and we can start looking at geographic variations in the data. I often get calls from citizens or politicians or other state departments wondering about the connection between especially our Superfund sites and possible cancers related to that. I can say that since about 2000, we have not confirmed any community cancer clusters in the state, and statewide our cancer rates are the same as the rest of the country, and that's true for many of the specific cancer sites also.
So you compare it to CDC rates or to other states? Or?
Yeah, so when I look at, for example, I'll use Butte as an example. They were recently doing a health assessment with their Superfund site, and they were also concerned about high rates of cancer. And so I'll consult, or I'll narrow in on what environmental contaminants are known to be in the area, and look at the literature to see what cancers are known to be caused by those contaminants, and then I'll look at the registry at those specific cancer sites and see how we compare to, how Butte compares to the rest of Montana, and then also how they compare to the rest of the country, and do an assessment that way. And I also will dive in a little deeper too and make sure that we're not seeing cases of really young people getting cancer that really shouldn't be, making sure that they are falling into, you know, like age ranges that we would expect. Because if a young person were to get cancer, that might be an indication that there's something going on environmentally that they're being exposed to in high doses that would cause early disease.
Because you probably have to take genetics in it.
Mm-hmm. Yeah. Yeah, and because so many of these cancers, too, there's so many risk factors, and really a person's cancer is determined based on like the risk, all the risk factors combined. You know, their family history, their age, smoking status, like what they're exposed to when they're a little kid, and then they moved somewhere, and what they were exposed to as an adult or a college student, et cetera, et cetera. It is complicated, and then the hard part also is that. We have we have information about where the person lived when they were diagnosed, but we have no information about where they grew up, where they spent a lot of their adulthood. We have some information about what they did for a living, their occupation. So those kind of investigations are tough. But as far as hotspot mapping and looking at like socioeconomic or socio-demographic factors that might be contributing to cancer in Montana, we're getting there to a point where we can look at that at the state health department.
That's great. Thank you.
Other questions? All right.
So I'm going to talk about the Behavioral Risk Factor Surveillance System. So I'm sure that you all have heard of it, BRFIS, as we so affectionately like to call it. And we already kind of got into that earlier when we were talking about surveys, but I'll just kind of go through some more stuff about it, not in too much depth. But it is a survey. It's a random digit dial telephone survey. So CDC has a contract with a company that creates lists of phone numbers that have a prefix for a specific area. And so it's a random phone number. It might not actually be a phone number that's in existence, but it has the prefix for whatever area, you know, you're looking at. And then we call those numbers, and we hope that we can get households. And within the household, we randomly select one adult who lives there, and then we ask them about their health. So that's basically how we do it, and it's available annually. So throughout the year, from January 1st until December 31st, we are calling people all year long, trying to reach our survey, our sample target. And for each interview, we ask them the same questions, and so we ask about how they are right there at that moment. So each person gets to answer about that day in their life, you know, where they are that day in their life. And it's not the same day for all of them, but that's why we call it a point prevalence. Okay? So BRFSS data will always produce prevalence. Because of the way that we collect the information, it cannot produce incidence rates. So that's important to remember. And then here's where you can get the state level estimates on the DPHHS website, public health /BRFSS. We can look at it later. I recommend going there first because all of the data is pretty easy to query, and it's broken down by demographics that make sense for Montana. So like the one that is the biggest thing that doesn't jive with us in the CDC is the race distribution, because CDC always does their analysis for white, black, Asian, and other, right? And we really need to look at white and American Indian. And so that's why I always say go to the state website first. And then you can get almost all the same stuff from CDC, but there's that. And then another thing that we do is the Smart BRFSS, and this is actually going away, but it's still relevant now. And that's where we oversample in the larger counties, in the metropolitan areas. And if we can get at least 500 respondents within a metropolitan, or actually micropolitan in Montana, statistical areas, so that includes Missoula, Bozeman, Havre, Helena, Kalispell, Butte, Great Falls, and Billings. Yeah, those are all of our areas that are micropolitan statistical areas, and usually it's just the county, but some of them have two counties, like Billings is Yellowstone and Carbon. And all of that is based on census rules about what is a micropolitan statistical area. It's kind of complicated, but if in any given survey year there are 500 respondents within those areas, then they can be weighted separately to look at just that county or just that group of counties. And then you can get direct estimates for your county in that year. So it's not every year. We try to, or we tried to sort of rotate through to make sure that each area got oversampled every 5 years or so. And that you would have 2 consecutive years where you were oversampled, because some questions are only asked in odd years and some questions are only asked in even years. But we are actually going to stop doing that because of the next slide. So it's still out there and it's still relevant. There's not data that is really like too old to be useful. So it's worth taking a look, especially since I think most of you are from the larger counties, so you can use it. It's not really any help to the smaller counties, but. And then small area estimation is sort of the reason that we're not going to be doing that anymore. And what it is trying to find a way to produce an estimate for counties that don't have enough sample size to do a direct estimate. So we can't just look at the survey responses and say with any kind of reliability that, you know, whatever % of people have heart disease. But we can look at all of the survey data and say, what are the demographic characteristics that put you at risk for heart disease? And say, well, you have this much risk if you're over this age, you have this much risk if you're this race and socioeconomic status and all of these things. And then we look at the distribution of those characteristics, those demographic characteristics in the county. And we use a really complicated formula, I like to call it statistics magic, to estimate based on the demographic characteristics what the percentage of people with heart disease is. So that's what small area estimation is. Does anyone want me to say that again or say it in a different way? Because it took me a while to wrap my brain around it too. Okay, so I'll go ahead and move on. But so
I have a question.
Sure.
I was paying attention to it, so I think I missed the main point, which is this is why smart purpose is going away. I missed that.
Yeah.
Less than that.
Okay, so we as a state put effort into oversampling counties so that we could do direct estimate, and CDC has developed this small area estimation they're going to do for the whole country, and they're going to put out estimates on the county level. And so not me personally, the BRFSS office made the decision to stop doing the oversampling, partially because it costs a lot of money, and also because we felt like you would be getting estimates from the small area estimation instead. But I want everyone to be really, really clear that this is not in any way directly measuring disease in those counties. It's using the probability of the disease based on demographic characteristics to say, probably based on your demographics, about this many people have the disease.
And that's based on national statistics then?
It's based on the county demographics, because the Census Bureau, the probability?
Yeah.
Yeah, so they can develop the probability formula based on the whole nation, or they could use the state level survey data to look at This year's survey respondents for the whole state of Montana looks like they're answering in this way based on like, you know, the demographics and correlating it with disease. I'm not sure exactly what the methods are. Quite frankly, it's really complicated. I'm not a statistician that does this kind of stuff, so that's why I call it statistics magic. Yeah.
Are they going to keep adding stuff that they do for, because that's a really cool website. I'm kind of bummed out to find out that it's not.
Oh, for SMART? Oh, yeah.
But I like it. It's easy.
Yeah, no, I mean, it's good, it's useful. The only thing that you should really be cautious about small area estimation is if you want to use it to evaluate a program that you're doing in your county, you shouldn't, because the estimate won't change based on your program. It's going to change based on your demographics. Okay, but it is, they did a lot of work to figure out a way to try to estimate this indirectly, and it is a pretty good estimate of the overall population. It's just not very good for program evaluation. Okay, but yeah, so the diabetes, obesity, and physical inactivity stuff has been out for a while, and I'm not sure when, but sometime, hopefully in the near future. They've been talking about this for about 6 years now, but maybe this time it's going to be soon. They're going to put out estimates that have a lot more information, and not just these 3 things, but almost everything that's on BRFSS. So you should really sort of keep your tabs on the CDC BRFSS website for that, because I think it's going to be useful, just with the one caveat. So the current coordinator for BRFSS is Emily Ehrlich, and so this is her contact information. She's definitely the person to call or email if you have questions, and she's talking to CDC about what's going on all the time. So,
is she able to do county breakdowns of births data for us, even ones that don't like get reported on your?
So sometimes it's a lot of work to try to put together years of data to get enough sample size to then re-weight it. So in order for her to produce county level estimates, she has to put together however many years of data to get at least 500 people, and then she has to re-weight. She has to do the weighting all over again because she can't use the CDC weight for it. And so I don't know if she would have the time or not. It doesn't hurt to ask. Never hurts to ask. And the more that you ask for stuff, the more that they know that it's a want and a need, and then that puts more impetus on making that a priority. So definitely ask, but I don't know that you'll get it. Yes?
So what do you know about NHANES and Montana data?
Okay, so NHANES is a national survey. They design their sample to represent the country. And because of that, there might not be any respondents from Montana. In fact, there usually isn't any respondents from Montana, like not even one. Okay, because when they draw their sample, they are sampling to be representative of the whole country. And unfortunately, Montana is a pretty small part of the whole country, so
people-wise.
People-wise.
Yeah.
Obviously, we think it's way super important,
Yeah.
But yeah, so big surveys like that, like NHANES, are not very helpful for getting Montana level data, just because of the way that they're designed. So that's kind of the bummer part of it.
But the NHANES on obesity, they actually do the measurements, correct? It's not.
Yeah, they actually measure.
The big problem with BRFSS is that it's self-reporting, and
Right.
especially
Yeah.
on obesity,
Mhm.
people think they're
Yes.
skinny as heck.
Yeah, you're right. That's true. And so, you know, with almost all public health data sources, you just have to recognize your limitations and try to make your interpretations based on what you know. Like, you know that people are going to underreport their weight and overreport their height. It's a given. People are going to do it. So.
The state of Oregon has some kind of, I don't know, if it was how they got it, but they took people's driver's license and the weight and height of driver's license to get their obesity rate.
Oh, that would be awesome.
You know, so.
Yeah, yeah.
Yeah.
I know, but I'm just saying that then you'd have more than 500 people though.
That's true. You could actually get county level estimates because it would be almost like a census. Not quite, because not everyone has a driver's license, but yeah.
Another thing I learned at a conference.
Yeah, that is cool. I've never heard of that, but maybe
Let's try to,
so,
want to try to get to an example.
yeah, so let's keep going a little bit. So we already talked about the youth risk behavioral surveillance system, so I won't talk about that again because we already sort of used it as an example. But here is the coordinator, Susan Court. She is staff of OPI. But anyway, so I won't go into that because I do want to make sure that we get a chance to go through examples. And then American Community Survey is where you can get a lot of demographic stuff. So it's really cool because it's from the census, but they do have estimates for small areas, even down to census tract. So it's really kind of cool about that.
This is what replaced the long form, if you remember that from the census. So.
It is a survey. They don't actually collect the information, but it's a survey that is designed specifically to be able to do estimates in small areas. They have to combine 5 years of data to do the really small ones, but still it's cool. And this is the kind of stuff that you can get from it. It's a lot. It's a lot. So if you are able to carve out some time to just explore, might be kind of frustrating, but it's worth it. Even more stuff. And then this is the important thing. So you can get 1 year estimates if the population of the area that you're looking at is 65,000 or more, which you can imagine is not very many places in Montana. You can get 3 year estimates if it's 20,000 or more. And then everything else, you can get a 5 year estimate. And the important thing is if you want to compare a big area to a small area, you have to use the same number of years estimate. So if the small area only has 5 year estimate, you have to look at the 5 year estimate for the big area in order to compare the two. And those are the counties that are available in 1 year. And those are the counties that are available in 3 year. And then obviously everything else is 5 years. They report margin of error, just so you know. It's plus or minus, whatever. That's just their style instead of a confidence interval. And those are the websites. And then the last thing that we'll go through real quick is the county health rankings. And so this is pulling together a lot of diverse data sources. And I want to tell you that all of the behavioral questions and the like prevalence of chronic diseases and stuff come from BRFSS, and it is small area estimation. So that's important to know. They also use ACS, the American Community Survey that I just talked about, and vital statistics and a lot of other things. And I think that as far as pulling together a lot of different data sources and making it pretty easy to look through the data, they're good. But we really don't want you to put a lot of stock into the rank. Because when they rank things, they're not looking at if it's a statistical difference or not. Rank 5 and rank 6 are probably not statistically different. And so just interpret with a grain of salt.
I actually heard a Robert Wood Johnson Foundation person talk about this at a conference. And he's like, we did the rankings solely to get people's attention. He's like, when people listen to it, people report on it, all that kind of stuff. He's like, we know it doesn't mean that much, but it's important for the attention.
Yeah, I mean, yeah, I get that. It's really, it makes a good headline if you're first or last in something, right? And so you probably know where to look them up. And so we put together these questions to let you guys practice, but since we don't have much time left, do people want to just sort of say what you want to look at, what you want us to go through? Yeah?
To be able to find the charges that hospitals, you said that that data is tracked, what the hospitals have charged, various.
Yeah, you'll have to make a request through Cody at DPHHS to be able to look at that. That's not posted anywhere.
It'd be interesting to see differences in charges through, at different hospitals around the state.
They won't
We can't
compare
do that.
hospitals. Yeah, they won't compare hospitals, but they could tell you among residents of a given place, they could say what the total charges are for a given admission, but they won't tell you what hospital it's at.
But will they tell you what county?
County of residence of the person. Yeah.
Well, and that's a statistics that's used, right, is like cost burden per person in the county or something like that.
Yeah.
From hospital stuff.
Yeah.
So she'd want to look at CDC Wonder.
Yeah, do you want to take them through Wonder?
Sure. Did you have a...
I'd love for you guys to see Wonder just because I found it super useful.
And Whiskers is kind of set up the same way, and it's really useful too for injury data. Yeah?
While she's doing that, could you talk about with the technology, the improvements in technology, how is that impacting our ability to collect data, social media, I know it's not accurate necessarily, but I know with like flu season, they track.
Yeah. So, well, at least as far as the chronic disease world is concerned, which is what I pay attention to the most, nobody has really like tapped into social media or, big data as far as chronic disease stuff is concerned. I think there is a lot going on with kind of like syndromic surveillance for like flu is a good example. And other like communicable diseases. Have you guys heard anything about people using that for chronic disease kind of stuff?
I've used it for asthma.
Oh, you have?
So that you can look up, that's based on chief complaint. So, for example, during wildfire season, we tried to look up if people were going to the emergency department more frequently with a chief complaint of asthma, shortness of breath, wheezing, something like that, to be able to kind of monitor the impact in a community. It is.
Wait, so what were you monitoring? The Google searches for?
That was in syndromic surveillance.
Oh, okay.
Mm-hmm.
The only, mapping is sort of the only other technology that we're starting to use, even in chronic disease, is just to sort of figure out how to geocode different things and then stick them on a map so that people have a visual of where different things are taking place, and then they can overlay other pieces of information to sort of make some conclusions there.
All right.
So here's the website for CDC Wonder, and there are a lot of choices here, but I think probably the one that most likely gets used is the compressed mortality. And then you're usually looking in the last 10 years or so. So this first choice, since they've switched to ICD-10, and you have to read the data agreement, say you are going to agree. And then
the screen up, Jesse, at all?
Blow it up?
Yeah, is there a way to make the screen bigger?
Yeah. Let's see.
Settings.
Is that better?
Is that better? Yeah, it's hard to see, yeah.
And then it'll run you through a lot of choices about what population you want to choose. So you can choose any of these things to group your results by.
So then you'll get an estimate for each group within that variable. So if you do years, and you select the range of 2010 to 2015, which 2015 data is not in here, but anyway, then you'll get an estimate for each year.
And then you can pick some of those things like we talked about. If you want it to be age adjusted, you want to see your 95% confidence interval, pick some choices there. Then you can say, I want to know it for the whole US, or I want to know it for a couple of states. We're going to choose Montana. These, and so you click on it and selected it. I think actually you can open it and then down to all the counties as well. You could do it by the urbanization codes. And then let's just come over here and say we want the most recent year of data. Usually they're a couple years behind in the CDC data. 2013. And then you have to kind of know a little bit about what you're looking for. So it's usually easiest to look for it by ICD-10 code. And the WHO has a really nice website to help you find the ICD-10 codes that you might be looking for. Here it's all categorized by those codes. So I happen to know that asthma is J46.
So this was hard for me when I first got in here to realize that you could open out the category and see more detail and then select things. So I just want to say that was hard for me to begin with. So you know, like to realize everything that has like a little, is it a little plus next to it?
Right.
Has more detail underneath that. You can either pick the whole category or you can open it and pick just one little piece of that category. So
you can pick as many things as you want, and a lot of these have different case definitions that go with them. And then you say send. Oh, right. Let's do it by...
Oh yeah, you have to group by something.
Race. It's probably going to be too small since I should have picked something much bigger, but there are only... So it's going to tell you that there weren't that many asthma-related deaths in 2013, and the only thing that they could calculate was an age-adjusted rate for white females. So there were 12 deaths in 2013. Here's the population of females that were considered at risk, and the crude rate, like we talked about, and then the age-adjusted rate. So you say, well, that's not really helpful. I want to go back. You can come up here and say, go back to your request form, and then start over.
And probably take off some of your filters. Instead of just looking at females, maybe look at all. Or,
right.
Yeah. Maybe do 3 years instead of just 1 year.
But how would all the females in Montana be at risk? You would only be at risk if you were diagnosed with asthma.
Right, so this is a rate that's based on total population. It's assuming that everybody has an equal chance of women, you know, out of all of them, how many of them died from asthma. It's not out of the population at risk that are diagnosed with asthma, I guess. It's out of all women.
Yeah, so at the beginning when I was like talking you through that was sort of like in the ideal world. And then when it comes to actually measuring it, a lot of times we just use the whole population because we don't always have a good estimate.
We don't always know how many women have asthma.
Yeah.
What about something else? We could look at whiskers too. Is there another one in Wonder? We only have maybe a minute or so left. Any other questions?
Is there a state that you like to compare Montana to that's similar with demographics?
Oh, that's a good question.
That is a good question. I don't know. Usually just
either.
compare to the nation.
Well, I don't know. Maybe Wyoming. Because Wyoming is also similarly small. I don't know how they compare with other demographics, but.
What about people are often asking for like counties to compare to, like other kind of common, and they often mean like university town in Washington or Colorado or wherever. I don't know. Are there is there any way to? I mean, like for instance, I got asked that on the community health assessment group a lot. They wanted comparisons with other counties, which we didn't end up doing because I couldn't figure out what the criteria would be to choose that. Is that a reasonable kind of comparison to make, or is it more just?
So, I think if you were going to try to pick some categories that you, or some characteristics that you would use to find a comparable group, I think probably age distribution and like socioeconomic status and I don't know, maybe race.
Yeah.
Gender distribution, maybe, although that doesn't vary a lot from place to place. I think those are the things that are probably the most related to disease, especially socioeconomic. Well, American Community Survey, that's how you find it. I mean, it would take a lot of looking to try to figure out, what's a comparable community.
We just get asked that so much that it might almost be worth the effort.
Yeah.
Yeah.
comparing for this data with some of like the similar Healthy People 2020 targets?
So, yeah, most of the 2020 target Healthy People 2020 stuff is based on like national surveys like NHANES and stuff. And I think if you want to try to use BRFSS measures, the important thing is to look at the question. So what question in NHANES versus what question in BRFSS, and see if the questions are really similar or not.
Right.
So I think it's a variable by variable kind of thing, whether or not you can kind of say this is almost the same. All right, well, we're actually over time.
Thank you.